Good evening to one and all present. My name is Alesh Shah, and my topic of research is evaluation of management in acute coronary syndrome, or ACS, and extent of adherence to standard treatment guidelines. Introduction. We all know ACS consists of three clinical diagnoses. That is STEMI, ST elevation myocardial infarction, non-STEMI, non-ST elevation elevated myocardial infarction, and unstable angina, or UA. Basically, ACS occurs because there is an imbalance between the myocyte requirement of oxygen and the supply of oxygen. So it occurs when there is a sudden decrease in the blood flow to the heart. India accounts for the highest number of ACS cases in the world, and yet we don't know much about what the treatment protocols are followed in India. And as we especially don't know anything about if these protocols are according to the recommendations that have been listed in the 2014 American Heart Association, American College of Cardiology guidelines. And even if they are following the recommendations, we don't know how, like, the quantitative measure of how much is followed, how much is not followed. And that is the aim of this project. That is, the study objectives are three: to evaluate the drugs used in ACS, to evaluate the prescriptions and adherence to the ACC-AHA guidelines, and to correlate the prescription adherence to guideline adherence with patient outcome. So methodology, the research started after getting the permission of ICMR, the Institutional Ethics Committee of the college, the HOD of the department, and the hospital superintendent. Basically, the patients were approached who were admitted in the hospital for any of the three symptoms, any of the three clinical diagnoses that mentioned above, and a consent was taken from the patient in their vernacular language. In the case record form that was filled later, the demographic data like name, age, sex, address, etc. was listed. With that, the history of present illness, past history, family history, and comorbid conditions were also noted. And the prescription, from there on, the prescription of the patient was followed from the day of admission to the day of discharge. So this is an example of the informed consent form. The same form was also translated to vernacular language and provided the patients. This is the case record form that was used to collect all the data. The study site was the cardiology department of a tertiary care hospital. Sample size was a duration-based study. Within an 8-week period time, the number of patients that we could get in the cardiology department, and we got 172 patients in the study. Study population was patients attending the cardiology department falling in the inclusion criteria. And study design was a prospective follow-up study from time of admission to discharge or eventual occurrence. So analysis, the data was analyzed for demographic characteristics, presenting complaints, morbidity pattern, comorbid conditions, and distribution of patients as per ACHA, ACC classification, and drug utilization patterns for ACS, as well as comorbid conditions. The main point of the study was the adherence to the ACC-AHA guidelines, and which was analyzed both quantitatively as well as qualitatively. And various tests like the Pearson correlation coefficient test, unpaired t-test, and Fisher's exact test were used. So the results and discussions. So basically, out of the 172 patients, we see that the highest number of patients fall in the 51 to 60 year age group. That is 65 patients. Most of them, a majority of them were male. That is 142 were male and 30 were female. So there was a ratio of 4.73:1. In the presenting complaints, chest pain was experienced by 128 of the patients. Ghabraman, as they described it in their vernacular language, was experienced by 131 patients, and perspiration by 130 patients. Other common complaints apart from those three were back pain, shoulder pain, breathlessness, chest discomfort, abdominal discomfort, uneasiness, and jaw and left arm pain, out of which uneasiness was the most common complaint. So now, as I said earlier, ACS consists of three clinical diagnoses. So out of which we found that STEMI had the highest number of cases with 77, followed by unstable angina and NSTEMI. In the patients of ACS, we also checked for CAD. So in that, single vessel disease, a double vessel disease, triple vessel disease, and left main coronary artery, out of which 166 of the 172 patients were diagnosed with some sort of CAD, and in which 56 patients were the highest number of patients detected with double vessel disease. Following that, we also checked for the presence or absence of left ventricular dysfunction. where 61 patients were diagnosed with mild left ventricular dysfunction. And we also checked for comorbid conditions and other risk factors associated with ACS. We found that 91 patients reported of having previous history of hypertension and 69 of diabetes mellitus type 2. For risk factors, majority of the patients, that is 153, reported that they had no addiction to smoking or tobacco, while 12 reported for smoking and 7 for tobacco. This is the total number of drugs given to a patient from the day of admission to the day of discharge. We see that 19 patients were prescribed 14 drugs and 18 patients were prescribed 12 drugs, and the majority of the patients fall in the range of 12 to 17 drugs. After that, we also analyzed the most common drugs that were drug classes that were prescribed. And in that, we see the P2Y12 inhibitors with the highest with 283. Now, kindly keep a note here that we had mentioned earlier that there were only 172 patients. But since several drugs were prescribed to patients in different dosage patterns and combinations, and hence exceed the total number of patients. So that's why the P2Y12 is more than 172, because they were prescribed in different dosage and combinations. So P2Y12 was given to approximately 283 different types of combinations and dosages. Aspirin 279, statins 195, and beta blockers 135. These are the four most common used drug classes. Those were drug classes after which we saw the most common drugs, and we see that aspirin is the most common drug given, that is 279, and followed by that we have ticagrelor at 171, rosuvastatin 146, and heparin 145. Now, this is a frequency distribution of the observed adherence patterns. As I had mentioned earlier, the main aim of the study was to see quantitatively as well as qualitatively how the prescription patterns adhere to the guidelines. So we saw that 118 patients out of the 172 were prescribed 100% according to the guidelines, whereas only 2 patients were prescribed with an adherence of 50% according to the guidelines, and the rest fall in between the two benchmarks. The average adherence for all the patients was 93.75%. This is the adherence pattern for each drug. So just a few things to keep in mind, that some of the drugs are prescribed to patients in different dosage and patterns, and only the relatively important cardiovascular drugs have been included, not all the drugs that are prescribed to the patients. And adherence counts for the overprescription of the respective drug as well as underprescription, so both. And we have graded the level of evidence or the adherence pattern. So most of them stay in the A to B range, which is a good level of adherence, a good level of evidence. As I said, we used the Pearson correlation efficiency test, and we found there is a statistically significant and positive correlation between the extent of prescription adherence to the standard treatment guidelines and drugs prescribed. As well, there is a statistically significant and negative correlation between the extent of prescription adherence to standard treatment guidelines and age of the patient. As the age of the patient increased, the physicians tended to deviate from the standard treatment guidelines for various factors. Frequency distribution of non-adherence to standard treatment guidelines. So we observed that ACE inhibitors were the most omitted drugs, and aldosterone antagonist was the most overprescribed drug class. This is the GFI of the 5 most common drug groups, and we see that the GFI value comes out to 86.46%, and with aspirin it is 100%. So conclusion, ACS is extensively prevalent around the world and the Indian subcontinent specifically, and ACS has a strong male preponderance with a 4.73:1 male to female ratio. STEMI was the most common, followed by unstable angina. An average of 14.66 plus minus 4.34 drugs were prescribed to the patients, and majority of the patients opted for PCI with or without having received fibrinolytic therapy at onset. Now, although no concrete Indian guidelines exist, we checked the prescription patterns with ACC AHA guidelines, and we observed that the average adherence was 93.75%, which is a very high level of adherence. And the success of this evidence-based medicine was well noted, with a 0% in hospital mortality rate, as in no patient passed away. All patients were treated successfully, and they were discharged with therapeutic success. ACE inhibitors were the most underprescribed drug, while aldosterone antagonists the most commonly overprescribed drug. A positive correlation between adherence and number of drugs, and a statistically significant but negative correlation between extent of adherence and age of the patient was observed. And these are my references. Thank you. Sir, would you like to ask a few questions?
Yes, yes. Okay, Adesh, good presentation. Okay, the topic is also good. Okay, the duration is 8 weeks. I think, as per your
Yeah.
presentation. Okay, so in 2019 or 2020, you have done.
No, sir, to 2019.
Okay, last year you have done.
Yeah, last year.
So with the ACH guideline, as you are saying with the adherence to the patient, you are saying that you have taken the ACS patient related to unstable angina and MI, right?
Yeah.
So it is diagnosis as per the written. You are just observing, na?
Yes, sir.
You
Like
can
the
also do.
physician
You
has
can
already
also
diagnosed
do.
the patient. I'm just
Yes, yes. You
observing
can
from there.
also do the drug interaction because above 14 drugs are prescribed as per the average number of drugs are very high. As per, how can you say that the adherence is this above 90%? How will you check this?
Sir, in the guidelines, it is mentioned that if the
Hmm.
patient has STEMI, then,
Hmm.
for example, if the patient does not have inferior wall STEMI, then giving beta blockers is a level of evidence, say A. So then we check like that. So if it's mentioned
Yes,
that
yes,
the patient should be given this
but
drug, then
in MI, when we are giving the drugs, in MI the cardiac enzyme, how much elevated, any comorbidities. So have you any checked that the comorbidities related with the difference in the prescription pattern? Because there are many comorbidities like hypertension, diabetes. So in diabetes, which drugs are preferred? Like in hypertension, diabetes, which drugs are preferred?
no, so we have not checked that till now, which drugs are
Yes.
preferred
So
and
it
which
is a
drugs are
part
not
of
preferred.
prescription pattern. You can do also later on from your Excel sheet. Number
Yes,
one,
sir.
I suggest you the morbidity pattern, the drug-wise prescription pattern. Second is you should also include the drug interaction because more than 14 drugs are prescribed every patient as an average.
Yes, sir.
Okay, so there is a drug interaction checker also which is available online. You can also do that. Okay, and the other thing is you are always saying P2Y12 inhibitors. So which drugs you expect maybe this is more commonly used from your study?
Sir, within the P2 by 12 inhibitors,
There are many
sir,
P2Y12 inhibitors.
ticagrelor is the most commonly used.
Which one?
Ticagrelor.
Yes. So when you are writing that T2Y12 inhibitors, only you have to specify when the result is you are preparing. Understand?
Yes, sir.
Because the group, when you are writing in the result, the group you should not write like the say P2Y12 inhibitors, COX inhibitors. Okay, we have to specify the drug name in the list of the because just below it is aspirin, I think, right? So we have to specify the drug, not whole COX2 inhibitors or NSAID. Understand?
Yes, sir.
Okay. The other thing is out of 8 weeks. Okay. So what is the average duration of admission? Do you know? Have you checked that?
Uh,
What is
no,
average
sir, we
duration of
haven't checked
admission on
that.
the patient? Because some patients will be discharged very early. So you can also do that. That is also very interesting because all of their are hurry in the discharge, right? So you can check that if the MI unstable angina is there, MI is there, right? What is the average duration of study that is admitted?
Yes, sir.
Okay, so you can also do that from your Excel sheet. What I have written, also do the multivariate analysis that I want to discuss with you. That multivariate analysis means if the patient has diabetes, and patient is described these drugs. Along with that, patient has this age. Along with that, this patient has this complication because many comorbid conditions are there. So, what is the analysis? What is the exact investigation, or what is the exact p value you can find from the SPSS software? That if the patient has a diabetes, you can have different covariate analyze. The patient has a hypertension with MI, the patient has a different p value because the patient has different prescription pattern, different admission, the different drug pattern also. So there are many things you can do via the multivariate analysis as per the age, sex, and the other things also, the ethnicity, whatever you want to check. Okay, so you can do better where before you publish this study. It is a good study, definitely, and you can publish in good journal. Yeah.
Yes,
Okay, that's
thank you
all
so much.
from me.
Next, we have Dr. Kinnari. Is Dr. Kinnari ready?
Yes.
Okay, I will be sharing the screen.
I'm sorry, actually, my PowerPoint has some animations. Can you please click all of them together so that I have all of my slide together?
Yeah, I will try. Yes. Dr. Kinnari, you can begin.
Yeah. So, a very good evening to all of you. Hope everyone is in good health. I'm Dr. Kinnari Thakur, third year resident pharmacology at GCS. This is due to the alterations in the pharmacokinetic and the pharmacodynamic properties during pregnancy. The transportation of the drugs across the placenta uh, may cause teratogenic effects, and so the risk-benefit ratio of the drug therapy must be carefully evaluated. Next, please. So this brings us to the objective of this study, which was to evaluate the drug prescribing pattern during pregnancy. Next, please. Yeah, so it was a prospective cross sectional study carried out at an antenatal clinic of a tertiary care teaching hospital in Ahmedabad. Can you please? Yeah. So the prescriptions of 500 pregnant females who attended the antenatal clinic were studied, and a one-time interview for the demographic details, any self-medications, any use of Ayurvedic medications, or any home remedies were recorded in a preset case record form. The analysis for various drug patterns was done using an MS Excel worksheet, and an ethical approval was taken from the institutional ethics committee. So coming on to the results and discussion part, let us take table one, which shows us the baseline characteristics. And it says that majority of the patients, like about 90% of the females, were in the age group of 21 to 35 years. Coming to the education, most of the females, about 71%, had had some schooling, that is, from the first to the 12th grade. About 26% were graduates and above, and only 3% of the females were completely illiterate. As far as occupation was concerned, majority were housewives, about 81%. Coming to the table two, next slide, please. Yeah. So table two shows us the obstetric history of the females. Majority of the females were in the third trimester, about 61%, and were multigravid. That is about 57% were multigravid. Coming on to table three, which shows us the prescription pattern of the drugs in these 500 females. So the total number of drugs was 1,299, and the maximum number of drugs were in the third trimester. Here it is because we had more females in the third trimester, and so there were more number of drugs in the third trimester, which we can make it more clear by seeing the average number of drugs per patient. So, which was almost similar in the second and third trimester, and it was 2.6 around. It was 2.6 drugs per patient. Then we also evaluated as to how many drugs were prescribed as FDCs. So majority, 85% of the drugs were prescribed as fixed dose combinations, and injectables were only 1.4% of the total number of drugs. Next, please. Yeah. So we had of the 500 females, we had 73 females who presented with some complaints, and commonly these complaints were vomiting, acidity, burning micturition, vaginal itching and discharge, cold, cough, fever, weakness, etc. And the common illnesses or the common comorbidities which were present were the thyroid disorders like hypothyroidism or hyperthyroidism, hypertension, and diabetes. Next, please. Yeah, so table 4 shows us the drugs prescribed as per the class. So this is the most important table which shows us. So vitamins and supplements formed the majority of the total number of drugs. They were about 81% of the total number of drugs. Antiemetics, here again, we can see we have divided into the first trimester, second trimester, and third trimester, and calculated the mean out of it because we had different number of females in each trimester. So in second and third trimester, the mean was almost similar. Antiemetics, as expected, they were total 3.8%, and as expected, they were majorly in the first trimester, 37. GI drugs and endocrinal drugs, they were less in the first trimester and almost similar average in the second and third trimester. Antimicrobials, which included the antibiotics and antifungals or antihelmintics, they were 1.5% of the total drugs, and they were none in the first trimester. They were only in the second and third trimester. Antihypertensives and the miscellaneous drugs, they were 4.7% of the total drugs. And again, the average of, the mean number of drugs was same all among all the three trimesters. Can we go to the next slide, please? Next slide, please. Sorry, back. Yeah. So this figure shows us we've divided the drugs into the FDA categories of drugs prescribed in pregnancy. There are 5 categories which have been given. This is especially for the pregnancy. So category A, B, C, D, and X. Majority of the drugs, almost 84%, it was in the category B and category C. There were none of the drugs belongs to category X, which is the most teratogenic, so which was good. Can we move ahead, please? Yeah. Also, table 5 here shows us the number of self medications, Ayurvedic medications used, and any home remedies in the 500 females. So we just tried to compare the educational status of the female and the amount of self-medication and Ayurvedic medication and home remedies. So we found out that illiterate females, obviously they were just 3% of our population. So, but then there were very less illiterates who did something on their own. The literate females, the school educated or the graduates and above, were more into self-medication and home remedies. Can we go next, please? Yeah, so the conclusion is the use of drugs during pregnancy is generally low, which is depicting a good awareness amongst the doctors as well as the pregnant females. Vitamins and supplements are the most commonly prescribed drug class, which was similar to other studies. And other medications are prescribed and taken only when necessary. No category X drugs that is teratogenic and unsafe were prescribed. And the self medications, which we said were more common among the literates, they were more commonly, they used to take antacids and analgesics on their own. So the self medications, the Ayurvedic medication, and the use of home remedies were more common in the literate females in our study. Thank you.
Thank you, Doctor. So, would you like to ask a few questions?
Okay, good presentation. There are a few questions
Thank you,
from
sir.
my side that, okay, one thing you missed is which the names of the drugs, because your is the main objective is the prescription pattern.
Yes, sir.
So you have class the name, let us say anti-emetics, but you have to
Yes, sir.
specify which injectables they have, let us say they have given iron or not. So you should specify 2 tables for oral, commonly prescribed,
Yeah.
and injectable, commonly prescribed.
Right, sir. Actually, I
Okay.
have all of them. The injectables more
Yeah.
commonly
So you
were
can say no
injection.
problem.
Yeah. Injectables were more commonly injection tetanus, and iron only one injectable was given for iron sucrose. And other antiemetics like doxylamine was the most common. A combination of doxylamine plus pyridoxine was the most common antiemetic which was used, followed by ondansetron in just 4 patients. Endocrinal drugs, as we said, included thyronorm, that is thyroid analogs. 3 patients were diabetics, so there were 3 anti-diabetics. There were 2 patients with hyperthyroidism, so there were 2 anti-thyroid medications. Antimicrobials, as I said, there were antibiotics, antifungals, and antihelmintics. So antibiotics were
Okay,
like,
can you say which antibiotics are safe in pregnancy?
so the penicillin group is more, and the cephalosporins.
So they have prescribed which antibiotic?
Cefixime, sir, and there was one cefixime. There were amoxicillin, that means a combination of amoxicillin and clavulanate. And there was just single patient who was given ceftriaxone plus tazobactam, which was
Okay,
IV.
okay. You said that 11 patients that received category D drugs, right?
Yes, sir.
Yeah. So do you know that category D, why they have prescribed this drug? Can you give this drug?
So
What do you
actually,
mean by category D?
yes, sir. So category D drugs, actually, these all categories have been divided as to how much risk it possesses. So the category D drug, it has got the evidence of human risk is present in the studies, but the potential benefits of these drugs, they may justify the potential risks of these drugs, and so it might, it can be used when it is really
Yes, yes.
necessary.
So one question will be there that 11 drugs, so in
Yes,
which
sir.
patients they are uh, giving. So if you have that data, you can also check this because if A, B, and C, that is up to that, it is okay for us. But when the D category they are prescribing, it is a confirmed teratogen drugs. Okay,
Yes, sir.
that is the reason. Okay, can you say one as you are in the third year resident? So can you say what is the difference between teratogenicity and phytopathic drugs?
Um, I'm sorry, sir. I'll just try. But yeah, teratogenicity is they may actually cause some disability and disformation, and phytopathic might be less severe than the teratogenic drugs.
No, no. Look, what happens? Okay, when the teratogenicity is, we all know, okay, that it
Right.
causes the uh, developmental this abnormalities, right?
Yes. Sir.
Okay,
Yes, sir.
but but the phytopathic, let us say I am saying you one example, ACE inhibitors, right?
Right, sir.
So ACE inhibitors when they are giving, let us say in the pregnancy when the patient is pregnant, so it
Hmm.
causes what? Do you know that which abnormalities to the fetus?
Um,
Let us say I am saying you ACE inhibitors, they may cause abortion. Some drugs causes abortion, some drug causes, pre-birth, matlab stillbirth.
yes, sir.
Some causes the neonatal death. So
Mm-hmm.
that drugs are not teratogen. They are the
Right.
phytopathic. Understand
Okay.
the
They
two
might.
different
Okay.
meanings?
Yes, sir.
One is developmental problem, and other they are directly damaging. Let us say the stillbirth, they can do abortion. Let us say so
Right.
that is the difference between these two. Okay. Other thing is when you are classifying the age, you can also the classify like this: less than 20, 20 to 25, 26 to 30, 31 to 35, and more than 30. So that is the better idea. You cannot directly go for 20 to 35. That
Common. Yes,
meaning
sir.
is very different because 20 to 30, 30 to 35, that is a big difference in between. So better you can subdivide this age group that is for your uh, that. Okay.
Right.
Other thing, which is your study site?
So GCS Hospital, Ahmedabad, GCS Medical College.
Okay, you have done there only. Okay.
Yes, sir.
Yeah. Okay, that is from my side. Okay. Thank you very much.
Thank you, sir.
Thank you, sir, and thank you, doctor. So we have actually had one cancellation today. Bonnie won't be presenting today as he's very sick. So we only have two presentations in pharmacology. So, sir, if you would like to say a few words and give the results if they have been decided.
Okay. Yeah. The presentation both. Okay. The Kinnari, right, and Alish both very well. Okay, as far as Alesh you are concerned, as far as you are in the third MBBS, it is very good efforts from your side also, and you have made a very nice presentation. And Kinnari also in the third year, pharmacology resident. Okay, so it is your presentation is also very nice. Actually, I am saying that my dissertation is also related what that you can also search on the Google. Okay, Harsh Joshi pregnancy. So you can find my article which is published. You can also use in your reference. Okay, so both have a very nicely presented. I just want to say one out of two. That is number one is Alish Shah. Okay, and number two is Kinmari Thake.
Okay, thank you, sir. So with that, we come to the end of today's presentations. We would like to thank all the participants and all the teachers